I wanted to do this history project because I wanted to capture those living events from the people that were actually involved in them at the time. I think it's important that we remember the giants that went before us, upon whose shoulders that we're actually now building gastroenterology. I wasn't there when Sherbaniuk and Wensel and Fred Weinstein were concocting and moving these things forward. But I wanted to capture them on video and have that forever.
The teaching in gastroenterology had been so poor. The only good lectures we got were from surgeons, and they mostly went to the surgical side of things. Because the teaching was so poor and there were no gastroenterologists in the province, that's why I picked gastroenterology. I took 2 years of medicine and a year of gastroenterology, and that qualified me to come back to Canada. And I phoned Don Wilson, who was our professor of medicine, and he said, "You're welcome to come back, Dick, but I don't think you can make a living as a gastroenterologist." He did advise me to take a second year, which was smart. So I took my 2 years and came back to it, and Bob Fraser in the meantime said, "Come back, we need you," because he had come back partly to build up the university. So I thought we should have a division of gastroenterology, and that's why I came back, to set up a division of GI. We didn't recognize subspecialties in Canada. In the United States, they did. And if you're going to organize a subspecialty, then it should be organized as that and not be part of general medicine, so that you come back and the way it was, if you wanted to be like Frank Elliott was interested in hematology, he had to practice internal medicine with an interest in hematology. Well, as a result of that, he never did any hematology. He was a general internist. So you never made any progress that way. And so I came back wanting to set up a division of gastroenterology. Brian Sproul came back wanting to set up a division of respirology. And Bob Fraser was already back, and he was setting up a division of cardiology. And that's the way we wanted it. Don Wilson was not convinced that we should do that we should have general medical wards as we did, and that we were a unified department of medicine, internal medicine, and no need for subspecialties. So you had to convince people that this sort of new administration and teaching was necessary. And so Don Wilson wasn't sure I could make a living as a gastroenterologist. The chief of orthopedics didn't think I could make a living as a gastroenterologist. It was just a different attitude. And it lasted because when George Goldsand went away, deciding to become a specialist in infectious diseases, and came back, everybody smirked and said, "Boy, he's going to have a tough time making a living. Anybody can order penicillin." Well, of course, now infectious diseases is a highly important and specialized specialty. But everybody had to fight the same fight to get people to recognize that. research funding. The best he could get me was $1,500 a year from either the Medical or National Research Council. What could you do with $1,500 a year? Nothing. Where was there a lab? Well, he had to, because he was the first guy back, he had taken part of a ward and set up his endocrine lab there. There was nothing else of it. So he said, why don't you take an afternoon off some Saturday and start up on the 6th floor where I have my lab and go through every floor of the hospital, including the basement, and then go through the Wells Pavilion, and then go through the Mewburn Pavilion, and see if you can find an old closet that isn't being used. We'll give that to you for your lab. In those days, the U of A had gotten by with part-time doctors teaching. That is, you'd run a practice and they'd ask you to run a clinic, 2 hours on Thursday morning or twice a week or what have you. And they got by that way, getting free teaching and paying almost nothing. When I started as a lecturer, I was paid $100 a year for all my teaching responsibilities. I was assisted by a fellow named Alan Gilbert. He was a student, he had a sense of humor, and he liked teaching, loved teaching, and the students loved him. And he'd had a little training in gastroenterology, so by default, he was handed much of the teaching in GI in the late 50s before I arrived. Then when I arrived immediately, he consulted with me, and the two of us ran the teaching in gastroenterology. And then when Wensel came in 1964, he was included, so the three of us split the teaching in gastroenterology.
The only other gastroenterologist was Dick Sherbaniuk. And there were no tools. The only gastroscope in the hospital had been there for 10 years. And it had 53 glass lenses end to end. And you could see a little bit of the stomach with it, like not much. And at the same time, there was a rigid esophagoscope that you put in like a sword swallower. So you could look at the esophagus and look at the stomach, but more or less blindly.
You had to get the patient's neck back, and if they have arthritis of the neck like I do, you can't get the neck back far enough. You can tear part of the esophagus going down because it's a metal tube, unyielding. So this was far more difficult, and it was a tougher job to do these procedures, and this is where you needed the skill to do it. That's why being an internist with an interest in gastroenterology wasn't good enough. You had to have the training to do these things.
The first years were tough because Dick and I were doing, Sherbaniuk and I were doing consults at the Misericordia, at the Old General Hospital, at the Royal Alec, and at the U, because we were the only gastroenterologists. And in certain situations, general internists fell in over their heads. And so we saw these consults after hours, at night, emergency, weekends, and that sort of stuff. The chairman of the Department of Medicine was a fellow named D.R. Wilson. And he did, he'd recruited cardiologists and pulmonary people and neurologists, and he didn't really know whether or not gastroenterology was real.
He ran the Department of Medicine the way it was always run. The wards were all general wards, and there were no divisions. And I go to a meeting in San Francisco in 1964, and who is sitting in the front row of the GI meeting, the National American GI meeting? Don Wilson, my chief of medicine, who is an endocrinologist. I said, "What are you doing here?" He said, "I came down to see what your specialty is all about." And he was impressed enough because he didn't understand gastroenterology. That was the point. That's why the teaching was so bad. He recognized that the subspecialties were not a general field that anybody could continue with, that the time had come to subspecialize. So the intent on my part was to establish a division. Same thing with Ron when he came. And we made this evident to Don Wilson, and Don Wilson recognized it. He recognized that there was this whole field that we had been teaching inadequately, that he didn't understand, and that it was time to move on in a modern fashion. So within a year, we changed the hospital wards. Each division got its own ward. Within another year or two, formal divisions were set up. We got offices. We had divisional directors. Everything was set up in a formal fashion, and the Department of Medicine was finally fully divisionalized.
Dick Sherbaniuk comes back from Detroit. Gastroenterology is not really a specialty yet from the Royal College standpoint, but they formed the Canadian Association of Gastroenterology, 11 members. And they focused around a yearly meeting. And Walter Mackenzie and Alan Gilbert were both early presidents of the Canadian Association of Gastroenterology. They weren't gastroenterologists, but they had developed this level of expertise around gastrointestinal health and disease that allowed them to become part of that society, lead that society.
The Royal College didn't recognize specialties in Canada. They did the British system, general internal medicine. And if you want to call yourself a special interest in gastroenterology, go ahead, but you're certified as an internist. So they decided in the late 60s, they recognized cardiology, so they had cardiology exams. They recognized pulmonary disease, and I don't know if there was another one or whether we were the third one, but they recognized gastroenterology. So then they established an examining committee, all members from Eastern Canada, where they had gastroenterologists in Toronto, Kingston, Montreal, Dalhousie. And on the committee, Al Gilbert from the University of Alberta, who did a little gastroenterology, this part-time stuff, and me. We were the two Westerners. I had to participate in doing the planning for the Clinical Sciences building, which is, I think, 12 stories. And GI was given the 7th floor, and I had to design this. But the money was so good that we could build the best labs possible on that floor. So we got first-rate equipment, research labs, examining rooms, offices. We even had our own X-ray unit on that ward so that you could do research that needed X-ray work. So then Walter Mackenzie said to me, Dick, you got to hire a full-timer to fill that lab you've got on the 7th floor. I had heard about Fred Weinstein at Seattle. Everybody thought very highly of him, and he was Canadian, and he wanted to come back. So by 1970, I'd put in my 10 years, so Ron Wensel took over as head of the division, and he had been in Seattle. So we hired Fred, we met Fred, and we got along very well, and we made a deal. He said, you've got to protect me. I want to do research, and I can't be taking phone calls all the time from referring doctors. So we did that with him, and later when Alan Thompson joined us, so that they had protected time in the lab while we did all the clinical work.
When I looked at the place, I liked the people, and there was an opportunity. I would have been the first full-time faculty member, because Ron Wensel and Dick Sherbaniuk were there. They worked all the time at the hospital. They were in private practice. And it just seemed like a good fit from a position point of view, from interpersonal point of view. When I came back to Edmonton, I had the hypothesis that the 25% or so of patients with dermatitis herpetiformis did not have celiac disease, that it might be inducible in them, that it could be induced like latent diabetes to show the predisposition. So I actually proved that. What I did is I set up a special biopsy laboratory just for gastrointestinal biopsies, which may be the first in Canada, I'm not sure, like we had in Seattle. And it just advanced the use of biopsy because you had proper processing. And I was blessed and lucky. There was a pathologist by the name of Theodore Schnittke there, because I needed to have the official blessing of the path department, because I'm not a pathologist, to sign them out, but somebody that I could work with who would sign out the biopsies, and he was there. And he was one of a kind. He'd gone to Johns Hopkins, he trained there, he raised African violets, he read everything, just a Renaissance man. Not just with medicine, but with everything. Yeah, and that was really one of these planetary accidental alignments that was just perfect. That was a highlight for me.
On Station 43 at the old University Hospital, there were 3 private rooms. And people had access to any of those, depending on how sick patients were. Well, the head of the Department of Pathology was sick, like real sick, and with chest disease. And all the pulmonologists came and saw him, the cardiologists came and saw him. They had no idea what to do. Then one day, from the depths of the pathology department, a fellow by the name of Ted Schnittke. Sorry, I'm crying over this. Ted Schnittke was probably the strongest academic in the faculty of medicine ever. And he came up and reviewed all the records and said, Dr. McGregor has Legionnaire's disease. This was 1977. It had just been described from an epidemic in Philadelphia. And Schnittke was right.
My role, as I saw it, was to make it a modern, in those days' terms, a modern teaching facility for gastroenterology. Not just for gastroenterologists, but for teaching residents gastroenterologists.
We wanted to train our own fellows. So it was a question, once the specialty was established by the Royal College, we would apply for accreditation. We had a full-time assistant professor, plus 2 very busy and well-recognized gastroenterologists part-time. We could have 1 fellow.
Dr. Bailey was a pistol. That's what I can tell you. Energetic, good sense of humor, patients liked him. Yeah, it was a delight to have.
Well, I wasn't sure what I wanted to do. I really liked internal medicine. And we're talking a long time ago here, so I wanted to be a diagnostician. Half the blood tests we have now we don't have. We didn't have an ultrasound. We didn't have endoscopy. We didn't have any of that stuff. Actually spent a long time taking histories and physicals and thinking about the patient. And so I went to infectious disease and said, what could you offer me? And I went to oncology, which I also liked, and said, what can you offer me? And then I caught Ron Wensel and said, listen, what have you guys got to offer me in gastroenterology? And they didn't say, this is what we can or can't do. They said, come and talk to us on Thursday. I think it was about a Tuesday. He says, come and talk to us on Thursday. So I showed up on Thursday, and Ron was there with Fred Weinstein. And they said, here's what we can offer. He and Fred Weinstein had met and sketched out what they thought would be a great program for a fellowship program, for the GI fellowship program. And it involved 6 weeks pediatrics, 6 weeks of radiology, and then working on the ward and in the ambulatory situation and in endoscopy, all to take place in a year. It sounded great, and I said, sign me up. And I did. It was wonderful. I had a great year. What did I learn as a fellow from those two in particular and Fred? This sounds pretty basic, but I got to tell you, it's the most important. I learned how to talk to people. Now, I didn't come into it not knowing, but they polished me. And then when I was in practice, I developed my own style, but the importance of talking to people, listening, that's it, not so much talking, listening, taking a history, examining the patient, and getting a working diagnosis. You're supposed to learn that in medical school. And we all pay lip service to that. And then I learned a lot of that as an intern, but internship was very practical. You were supposed to learn practical things so you could go into practice. And then as an internal medicine resident, as say, you learned the recipe and how to do it and then how to think a little bit. But I think how to deal with people and how to think about the disease and then incorporate those things into the practice. They didn't preach at me, but you watched how they did it. Dick, a little more wordy, a lot more time on physical exam.
I ask the patients to keep their hands by their sides because if the hands are up this way, there's a tendency to tighten the abdomen, hands by the sides, knees up, head to the left, and I ask the patient to look at the wall, and if they have a sense of humor, suggest to them that they think tranquil thoughts.
Ron, a little bit more assertive, a little bit more direct in his approach, but you learn from both. The combination was very good.
When did you first develop the symptoms that brought you to see me?
Fred made you think of the pathophysiology and then made you support your working diagnosis and eventually your real diagnosis with data.
The fellows in the clinic would see the patients first and then present the patient to me before we went in, and then I'd ask follow-up questions. And in some instances, I would, or in maybe many, or some instances, I would point out how you can get more probative information by asking a certain question a certain way.
Could you tell me, please, what brought you to see the doctor the first time? Was it a steady kind of a pain? Now, you say you had this pain for 1 week prior to coming to the emergency here?
Did I learn from those guys? You be sure I learned from those guys. I learned from everybody along the line, but boy, they were very instrumental in helping me. And you be sure, the same with all the fellows as they went along. After my year, 2 residents moved into GI, Dr. Jim Piercy and Dr. Dennis Todoruk. Jim had been a junior resident with me when I was a senior resident in internal medicine, and we were great friends, great buddies. And so I like to think that I influenced him to move into gastroenterology, and he got along again extremely well. He was an outgoing, vivacious guy and had a good time. Dennis Todoruk, and Dennis I think Dennis was very interested in pulmonary medicine. And I think I said to Dennis, you know, pulmonary medicine's okay, Dennis, but let me tell you where the action is and where you should be. And encouraged Dennis to change his thinking and go into gastroenterology.
At the end of my second year, after I passed my exams for medicine, I was all lined up and accepted into the program of pulmonology and ICU, and then Bob Bailey, one of my senior resident, who I knew very well at the time, and he asked me what I was going to do, and I said, I'm going to do pulmonology, and he advised me strongly against it because he said, well, look, you know, they don't have a very good program, and they didn't. The programs in those days for the senior resident, if you were going to go into a specialty, you're sort of the in-between person. You manage things for the staff. It was like you learned by osmosis. You did a lot of things, and you ran a lot of things. It was just as doing. It was more of an apprenticeship. The GI program, when Fred Weinstein came here, he changed everything. It was more regimented. You'd have a certain amount of time for certain different disciplines. There would be several months for endoscopy, there would be several months on the ward, there would be several months on consults, a month on pediatrics, a month on pathology, a month on radiology. So you had all these strict disciplines that were separate from the ongoing program, whereas in the other disciplines, you had all that. There was no concentration on any one area. Whereas in GI, you'd go in there, you'd work with Dr. Christopoulos, who we considered the god in radiology, because if he said something, it was there. I mean, he probably could do as well in defining a problem radiologically by doing a barium enema as well as doing colonoscopies. He was that good. And so we would work with him and several of the other radiologists, and we'd do the radiology. We'd do the barium enemas, we'd do the follow-throughs. And so we took part in the program, and so you learned a lot more that way. And we really got a good overall introduction and practice of gastroenterology. So it was a very, very good program. Very different for the time. I was the first one in, and then the same thing happened to Dr. Piercy. This happened to me. Bob Bailey convinced Dr. Piercy not to go into oncology, but to go into the GI program, and he too did the same thing I did. And they decided they would take both of us. And then Huey Freeman came in our last year. That was his first year.
I did some rotations in various specialties, and I ended up on one of my specialties in gastroenterology. And by this time, I'd already met most of the faculty then, Dr. Sherbaniuk, Dr. Wensel, and Dr. Weinstein, who were starting a program out. Dr. Bailey was actually their first fellow, so he would come around and see a consultation, and he was a very good teaching person, and so were the teachers. And so I think that was something that influenced me in terms of what I wanted to do. They were only allowed to fund one fellow per year. So at that time there was Dr. Bailey, and then they had accepted Dr. Todoruk. And at the very last minute, Dr. Piercy, who was planning to go into something else, I think he was thinking about oncology, changed his mind. And so they scrambled and so on and took Dr. Piercy in the same year. So there were two in that year. And I had already sort of indicated that I was thinking about going into gastroenterology as well. So I soon found out that there may not be any funding for me to go into gastroenterology. So I spoke to Dr. Weinstein and Dr. Watanabe at the time, who was an endocrinologist who was a very great supporter. He ended up going to Calgary as the head of medicine there. They said, you want to do this gastroenterology, we've got a way, and you can do it by applying for funding for the Medical Research Council. And I thought, oh, okay, well, I think I should try that. So it was just an accident that I ended up in that direction, because, you know, it was actually turned out to be outstanding for me, because I ended up getting a whole career, not only in gastroenterology, but I ended up basically becoming well-trained in gastrointestinal pathology. Actually, at that time, the university hospital, you know, had some pretty outstanding individual people. I mean, there was a guy by the name of Kostopoulos. He was a radiologist. He was a very animated kind of teacher, and I think we all sort of got to really enjoy his expertise. He actually, it was a sort of a tragedy in a way, because while I was a fellow in Edmonton, he actually was presenting at a meeting in New York and actually had a heart attack and died in a meeting. And he was probably one of the most outstanding radiologists that, you know, Canada ever had.
Fred, because he was younger, he had a better rapport with students than we did. They really liked him, and he made a special effort with teaching. He was to be the full-time teacher, but he made a really special effort, and everybody loved him.
I try to encourage that they ask questions. If you don't understand something, ask questions. And you won't get into trouble, and if you do, you let me know. So that was really the main objective, was to try to create a spirit of inquiry.
The closest interaction was with Dr. Weinstein. I mean, we were his kids. It was really funny. I remember when Dr. Piercy and I were sitting down discussing things with Dr. Weinstein. Every Monday morning we would meet with him, and one of the earlier meetings, I can't say exactly when he said to me, look, he says, if I yell at you, if I criticize you, don't take it personally. So he'd come and he'd be grumpy as heck on a Monday morning. You'd come and sit down in front of him, and he'd say, why didn't you do this and why didn't you do that? And you'd perspire a little bit because you didn't know what would happen. And later he'd say, okay, you know, just don't worry about it, let's go. And that's the way it was. Dr. Sherbaniuk and Dr. Wensel were teaching us ERCPs, but they were learning ERCPs themselves. They went to Seattle for a week and picked up a few of the nuances and on doing the techniques, and they're coming back and they would be practicing, and we'd be there with them for 2.5 hours, 3 hours, and then we'd be watching, and then they'd let us do a little bit after they finished, after they were successful. And that's how we learned. They were very innovative, and they were always, whenever something new was on the horizon, they would go and find out what it's all about and then implement it. With ERCPs, we were one of the first in Canada to start doing them.
One of the major changes in gastroenterology from when I got in the door till actually I left the door as a trainee was the development of fiber optic endoscopy. And now it's routine. But imagine being able to put a hose into somebody's stomach and look around and see ulcers and see cancers and see bleeding that we could never do before. When you were learning how to do that, you had to attach a second tube onto the end. So imagine you have this thing you hold in your hand and it's got a tube. But if you want to learn, and when you're doing it, you have to look in. Imagine, so you're looking in and you want to share the teaching an info with somebody, you clicked on a second little hose and they looked, but it stole half the light. So it was dark, you could hardly see. Now it's all done with cameras and videos, and it's spectacular. However, that began when I was a fellow. I had nothing to do with it. I was along for the ride. But Dick and Ron brought that to the city, and man, I tell you that, I mean, that was wonderful.
We got to go to a major meeting once a year. And it was very interesting because Dr. Weinstein, or Dr. Wensel and Dr. Sherbaniuk paid for us to go. They would take money from the consult service, that was their money that they earned, and they would put it in a kitty for us, and they would pay our trip. They'd pay our airfare, pay our hotel, and pay the course, which was very nice.
Ron Wensel, for example, would do the ambulatory clinic, and I would see the patient, and he would come over and go over it with me, and then some of the, I guess the fees that he was supposedly paid got put into the divisional account, and it was, I mean, it was a double whammy for him because he had to provide the money. He got paid, but he gave it his time and the money that he made for seeing the patient to the program, and so that allowed us to go often to the meetings, and and it was an important learning development for us, and they recognized that and insisted that we go.
Just to show you how they supported me, after I finished gastroenterology, I wanted to go and learn some more. And I ended up going to England to Roger Williams Liver Unit for 2.5 years. During the interval, I didn't start there until the very first week of 1974. So Dick and Ron had me apply for and supported me getting privileges at the University Hospital to work as a staff member from September till December, just to make sure that I was looked after. So it wasn't just, you were a resident, thank you very much, you're done. They looked after me. And by that time, Ron was on the Canadian Liver Foundation board, and I applied for a scholarship, fellowship support for liver disease. And Ron was instrumental in saying, listen, this is available to you, apply and we'll support you, which they did. So you can see how they were part of my whole life.
Ron Wensel, when I came back to Edmonton, he felt really, because he had me come back twice. He was the division head at the time. And once, then they only had a limited amount of funding and they couldn't really offer me a real solid job. And then the next time was, he did offer me a good job, but he knew that I wasn't going to come back. But he said, I'm going to write it down for you anyway, and you can take the letter and give it to your department head and see if he can match it. And he did. But it was a much improved situation for me after that. So all of those things are small items, but you remember them pretty heavily.
We started to do endoscopy in the back room in the emergency department, and asked an emergency room nurse whether they could help us. Well, then, after each case, in those days we used much heavier sedation than they do now, we lined the cases, the post-operative cases, up in the hallways, and sometimes we had 6 or 8 people on end-to-end stretchers between our back room and the front of the emergency department, and it was safe because there were people walking by every 30 seconds, and they could tell us whether or not some of these patients were in trouble. We pleaded to get new gastroscopes, pleaded to have better facilities.
by the mid-70s, when the good scopes were out and we were doing both gastroscopies and colonoscopies, then we had to have a full-time room which we ran from 7 or 8 in the morning to as late as 11 o'clock at night. This is the way we practiced. We worked really hard and supported Fred and then Alan Thompson, and that's the way we got the division established. We really worked very hard at this. I mean, Ron and I ran 40 inpatients. That's a lot of patients to see every day, plus an office downtown. And then when the new scopes came out in the 1970s, you spent most of the morning doing endoscopy. So you ended up working an 80-hour week, sometimes 90 hours.
Dick Sherbaniuk and I never had a personal problem. We always got along. He might think one thing, I might think another, but it was never an issue. But part of the reason is that we worked different schedules. To give you an example, my mother lived in a small building near the Le Marchand Mansion. This is after a while. Dick and I had an office at the Le Marchand Mansion, very nice. But I would drop in the morning and have coffee with my mother, and then sometimes take a tape, an old-fashioned dictation tape, over to the my office to leave for my secretary. And on several occasions, Dick was there, sound asleep, with his head on the desk. He often got to the office late, and real late, and he had a group of patients who loved him, absolutely loved him. And they would wait forever. And they had their own club. They brought their knitting, they brought their family pictures, they had stories, and some people, having had an appointment with Dick, didn't stay. But most of them, once he'd seen them, stayed forever. Dick and I always had some degree of competition as to the number of beds occupied on Station 43. There was 35, as I recall, beds. And we each had a card of a different color for the patient. So there would be blue for Dick and green for me.
No, other way around. I was green and you were blue.
Okay. And on one occasion, my ambition was to obliterate Dick. And I got 34 patients of mine on the ward, and I couldn't get rid of the 35th. But I still think that Dick probably over-investigated and did more endoscopies than I did.
Come on, Ron. This came out when that Belgian published his paper showing that you can't treat a Crohn's patient properly until you endoscope them and see whether they're healed or not. And for too many years, doctors didn't bother scoping their patients. How many doctors didn't re-scope their ulcerative colitis patients? They didn't know if they were healed or not.
Dick's quite right about that, and this re-scoping. But now Dick carried to an extreme, because he would scope many patients monthly. Fact.
No question. If a patient had ulcerative colitis, I'd scope in a month. Are they healed or not?
Well,
if they were healed, the treatment changed. If they weren't healed, I had to continue the same treatment or adjust it upwards.
But the natural history of that disease is that it takes a while for the treatment to become effective. Well, and I thought monthly endoscopy was...
Yours may take that long. Mine, with my treatment, they got better in a month, or I was disappointed.
Okay, well, true. Okay.
Well, we did argue about some things. We would argue about numbers of beds and endoscopy time. No question of that. And he would always try to get Weinstein to side with him. And Fred would bend over backwards to be equal to both of us, which is why we all got along so well.
That's absolutely correct.
It was great working with him. It was really, I would say, in terms of my working interactions in my career, it was one of the highlights. We got along, and I loved their contrasting styles.
He was a stabilizing force. He was pretty easy to work with from their perspective. He made them click together. And that was really important, because if you didn't get them to click together, then the program wouldn't succeed. but he did that.
Fred was probably the most skilled GI histopathologist in Canada, without question. And in fact, Fred was that good at all that stuff that CURE, the Center for Ulcer Research and Education in Los Angeles, came and said, Fred, you know what, we need you.
He started off going to the States to work with the fellows in his field, which was the microscopy of the tissues of the intestinal tract, to keep up to date. So he started publishing, and he became sort of world famous. And that is why they hired him to join them in California. He'd done such a good job. Tremendous teaching loss.
I mean, he was really the foundation of our division, because he got it going, and he knew what was necessary. Dick and I were just clinical doctors, and he was a true academic. He was a good teacher, knew the literature well, commanded great respect, and everyone loved him.
My time in Edmonton as my first academic job allowed me to move on to a phase of my career where I could exercise ideas that I had in a framework that really permitted it, that was very conducive to allowing you to do that, and permit me to set up my research and to work with two fellows, Dick Sherbaniuk and Ron Wensel, who were really very encouraging, and we were partners. We had different jobs, but we were partners. And it was a wonderful environment. It was really a wonderful environment.
We were brokenhearted to see him go, because he had helped Ron with the running of the division. When he quit, Dr. Wensel had put in 10 years, so he quit. And now we needed a new division head. Well, the chairman of the department by then was George Molnar, an old friend of mine. And for some reason, I don't know whether he didn't have funding or what, he didn't want to hire a new head. So he suggested that our division members elect a head. And they elected me for another 5 years. So until 1986, I was head of the division again.
They were in full flight at that time. I mean, they were leaders in the community, they were leaders in gastroenterology. They were avidly going to all of the meetings around the world, bringing back all this new knowledge. And these were two private practice gastroenterologists.
Despite the fact that they were so busy, they also got involved in hospital committees. They got involved with the college. They got involved with the aspects of medical care in the community. Both Dick and Ron, in their turn, were president of the Edmonton Internists Association. Ron was involved in the Canadian Liver Foundation in establishing liver disease, at least the organization of liver disease in Canada. Dick was very involved in the Canadian Association of Gastroenterology. So here are these two men in private practice, truly dynamos in Edmonton with the size of their practice, and got a division of gastroenterology going, went out of their way to recruit, got Weinstein, got Thompson, got the division going, got involved with all the committees that were necessary in the Department of Medicine in the university and the university hospital, involved in the city, involved in the college, involved in Canada, and not just one shot, for most of their busy, active lives.
I wouldn't have thrived at another hospital. First of all, I grew up across the street from the University Hospital. I used to drive to class, to the old medical school, which was 4 blocks. But I just identified with the hospital. And when I retired, they gave me a picture, a painting of the Mewburn Pavilion through 5 trees that my father had planted in 1938. So I've been at the university for a long time.
I sort of stayed on doing endoscopy, and Fedorik particularly wanted me to cover the ward because a lot of the other guys didn't want to do ward work. They had other things to do, particularly the researchers. So then I hit 70, and at 70 you had to be reviewed and you were appointed every year. And I was going to quit, and Fedorik said, why don't you stay on for another 6 months? We need you. Well, 6 months became a year, became 2 years, so I ended up staying till 2012.
Dick Sherbaniuk continued to do clinical practice. I think we had 4 or 5 retirement parties for Dick, and he never really did retire. He stopped doing endoscopy when he was, and I'm not going to get the ages right, but probably around 70. But he continued to have a large clinical practice. By that time, I was the divisional director in gastroenterology, and I would get Dick privileges so that he could continue to see his patients. And I think he saw his patients well into his 80s. Same style, they'd be booked at 2 o'clock, he'd show up at 4 o'clock, and 10 o'clock he's still there. It was always like that.
We got a fellowship training program, and that was the key, because it would improve all of us. That was the key. We had to, because of a fellowship program, we had to aim higher ourselves.
The one thing that the early program did, it generated an interest in other residents to want to become gastroenterologists once they saw what we were doing and how things were working out for us. And it became a very appealing program, one of the most appealing programs. So we were able to attract more and more people as the years went on because of people found it a good program.
As you look at the importance of the training program at the University of Alberta, and now I'm looking at it from a broad sweep of things, leaders in gastroenterology in Canada have come out of that program. Organizers and teachers have come out of that program.
The Dean of Medicine in Alberta is Richard Fedorik, a gastroenterologist, and the Dean of Medicine in Calgary is a gastroenterologist, and his name is Mettings. They both went through our training program.
As you choose your careers in medicine and maybe in other professions, you obviously have to be turned on and like something. It has to be of interest to you. If it's not of interest to you, you're unlikely to choose that as a career. So that's the first bit. The second bit is I think often you have to identify what I today call heroes. People that you could look at, identify with, and say, I could be like that person. I could see myself doing that type of job. And in the gastroenterologists that were here at that time that I had interaction with, and Fred Weinstein, Bob Bailey, and Dennis Toderick, those 3 specifically that I knew the most, they were individuals in whom I said, well, I like gastroenterology and I could see myself doing their jobs. And so that's kind of what led me to decide that I would be a gastroenterologist.
We've got adequate funding now. We've published enough papers. We're world famous. We've got a world-class division.
It's a powerhouse in Canada. People have gone through the program and have become very prominent elsewhere. That's good. So I'm proud of the division.
They introduced gastroenterology as a major field. And at that time, it wasn't uncommon that a lot of people who were doing gastroenterology were internists. We're all internists, but who would do internal medicine and do a little bit of gastroenterology. They made the field a specialty in itself. And of course, Dr. Weinstein helped that, and successive people who were here helped that too, but it defined the division as a standalone. You could go out into practice and be a gastroenterologist, and that's what you're going to be.
If you look now in the city of Edmonton alone, the Misericordia Hospital has 5 or 6 gastroenterologists. The Grey Nuns Hospital is, I think, 4 gastroenterologists. There are going to be 20-some gastroenterologists at the University Hospital. At the ALEC, there are 14 of us. And of the 14, 4 are alternate funding physicians or gastroenterologists. That means that they're part of the university full-time faculty. And then there are 10 of us in private practice. And so if you think we started with 2 gastroenterologists at the University Hospital and then the university, added a third, Weinstein, and spread from there, look at the influence of the Division of Gastroenterology in the city of Edmonton, let alone across Canada.
Alberta is a bit of a pioneer spirit. I think they had that pioneer spirit as they took it upon themselves to develop something, and I think we still have that pioneer spirit here, and we can continue to develop medicine in all specialties and in this faculty of medicine and dentistry, using that pioneer spirit, driving for excellence, and really not only helping the people of Alberta, but changing the way we practice medicine, being part of the tremendous change that is happening in medicine now, and leading that change.
Well, I guess what both Dick and I wanted to do was to be the best doctors possible in the field of gastroenterology, which was new in Edmonton, and we introduced it. So I think we both had that vision of providing service and academic leadership to the extent that we could.
What Ron and I have often said was that we had the privilege of practicing gastroenterology in the best 50 years that we can imagine.
Dick's absolutely right. We were the forerunners and the opportunity to...
So many new things, so much new technology, so many advances. It was a gas.
Yeah. It was fun to come to work every day, absolutely. And for you sometimes to go home.
I missed that. I seldom went home.